So I'm talking to you here about our plans for follow-up for our paediatric cohort. And one of the things I want to think about is the complications of cord injury. Now, there are some complications which overlap between adult cord injury and paediatric cord injury. There are some things which you see in paediatric cord injury, not so much in adults. So for example, on this side here, the skeletal development, puberty, and the metabolic changes alongside the community reintegration, education and socialization. These are things that don't tend to get thought about in the adult population, and it's not that they are necessarily more important than this side of the board, but they are additional things to consider. What I want you to take away from this slide is that there's every organ system of the body that's affected by paediatric cord injury. Earlier on we were discussing children that are labelled as having recovered from their paediatric spinal cord injury, but still have bladder involvement, still have bowel involvement, still have sexual dysfunction. It's about that whole picture. Now, I'm not going to ask for a show of hands, but I want you to think about this. Have you in this room planned meticulously for your retirement? Right? Just have a think about that. For some, the answer will be yes. For some, the answer will be no. But what I would ask you is, put your hand up if you are never going to retire. Okay. No. So this is the point, really. We talk lots about paediatric cord injury, and my slides I deliberately make childish to remind me about who's at the centre of all of this. It's not us up here on a stage, it's the children that are experiencing this and living with it. But every time we see these children, we have to think about not only where they are now, but where they're going to be throughout the rest of their life. And simply on a biological disease model, we need to think about what are the complications immediately. How are they managing their bladder now? How often are they getting urinary tract infections? How can we reduce that? But at the same time, be thinking about their skeletal organ system. And if we get the 16 or 17-year-old to be standing now, that's a real struggle, because they've decided, like all mid-teenagers, they know everything they're ever going to know. Anyone that's older than them doesn't have any idea about anything.
Can't go
not
for
here.
Yeah.
But we've got to think about that is staving off the degree of osteoporosis that we are all eventually going to develop, but that's going to move it even further back in our lifetimes. So you have this really unique ability when following up children to not only affect their health now, but their longer term abilities over their entire lifespan. Now this is important because here's a map which I drew because AI, when I tried to draw this, sent me to all kinds of places around the globe, so I had to do it by hand. Now, I want to give some credit here to our physiotherapist, Kirsten Hart, who sat in the audience now and is wondering whether I'm going to ask her to stand up to take credit for this. She's shaking her head, she's not going to. But this is about that green line there, in a perfect world, planes don't quite operate this way, is the straight line distance from London to Gothenburg. The first red line below it is a 2-degree deviation. The second red line below it is a 5-degree deviation. Now I did look at a map as to which Swedish towns I would finish in if I was at the end of those lines. Then I decided that I wouldn't offend you by trying to pronounce them. But the point is, a very, very small deviation at London gives you a very different outcome by the time you get to Sweden. And this is the same with paediatric cord injury. If you don't get it right when these are young children, the knock-on effects later on in life are much more serious. In addition, I've never been to Sweden before. So I landed in Gothenburg and got picked up and I've been exploring the city. But if I had landed somewhere else, it would have taken me quite some time to work out I wasn't in Gothenburg, because I didn't know what Gothenburg was like. And I invite you to think about this for paediatric spinal cord injury patients and their families. For most families, they will have one experience of paediatric spinal cord injury, and they don't know what the possible destinations are or how that would look like en route. This is where those with the experience of numbers of patients with cord injury then come in useful. So, at the National Spinal Injuries Centre, this is our UK programme. We have, for most patients, an initial admission, which is an inpatient stay with us, during which we undertake assessment and treatment. The length of that stay will depend upon the individual needs of that child and family, but they will have their entire MDT follow-up. And I want to emphasise this. We've come here, as Monica says, with our paediatric MDT, because this isn't just about seeing one individual. You need all of those people around that patient and the combined 136 years of spinal cord injury within that meeting in order to get the best outcome, so that you remain on that true course and not 2 degrees or 5 degrees off. After the initial admission, we will then have a first follow-up. So all these patients will be called by our clinical nurse specialist at 6 weeks post-discharge, and that really finds out who's doing well and who's not and what the upcoming problems might be. We will then see them in clinic face-to-face at 3 months. Now, children will come to us from various places, all over the UK, but also places like Malta, who have reciprocal arrangements with us. So we'll have international patients flying in for this. After that first follow-up, all being well, most of these children will have what we call an annual developmental review. So rather than going to various different places to talk to one person about urology and someone else about respiratory function and someone else about bowel function, they will come to us for a week. And in that week, we will review them as an entire person, undertake whatever scanning and investigations are required in order to make sure we're staying on that true course. And most will return on an annual basis for this. At the moment, we're conducting about 126 of these reviews a year, and it just means that all of your care is condensed into that week. Now, that's not to say that we don't have any intervention outside of that. We will have ongoing discussions with community teams about these children and young people in terms of following up their needs. That annual developmental review consists of many things. So firstly, we have a specialist paediatric cord injury MDT. That's what we do. That's our bread and butter. That's what we see every day for our careers. We also have early detection of deterioration. Now that might be because the young person is saying something to you, such as, yeah, my bowels haven't worked as well as they did over the past couple of months. Now, if I'm a GP, as we would call it, or family practitioner, who has 10 minutes to sort out whatever problem is going on, I will see lots of children whose bowels are a bit fluctuant and not necessarily worry about it. But for us, this may indicate a change in their neurological function. So it's about having that experience of spinal cord injury, working in tandem with that family and young person who know what is normal for them, and being able to pick up early any change. Similarly, with the screening programs that we have, including for hip development and scoliosis, or kyphoscoliosis I should say, we can pick up these early changes to work out what is going to be a problem and what is taking us off of that true course. One of the most important things we do, and our physio in charge of this is in the audience, but I would say this whether she was here or not, orthotics. Because with our data, we find that we can prevent a lot of these children, even relatively young injured, going on to need surgery because their kyphoscoliosis has deteriorated. Now, this intervention in our case tends to be not rigid bracing, but reinforced corsetry, which is tolerated and tend to find better by children than having a hard plastic brace. If they can wear the hard plastic brace, great, but a lot of kids will decide I'm not doing that. I will come on in a bit to talk about adolescence, and that's where the real storms come in. One of the things we do, which has nothing to do with me, has very little to do with the team, is peer support. A lot of these children, when they are injured, will either be in a situation where they are the only child with a cord injury there. Other children will come in, will get better from their acute illness and will go away. And this child's left there thinking, well, there must be something absolutely dreadfully wrong with me then, because everyone else is changing and I'm not. The other end of that spectrum are children that are in intensive care units, because they have a tetraplegia classically. Other children come in, and a lot of those children sadly don't leave the hospital and end up passing away from whatever their condition is. And again, this child is left there seeing all of this, most of the time without a brain injury, so cognitively they see what's going on around them. Very often I see families come in, and after the first couple of days in the unit, those families are knit together because they're sharing an experience that I don't have. With the best will in the world, I can't say to them, I understand what they're going through, I'm not going through it. But there they find other people who are going through something similar. And those friendships are quite interesting to watch. It causes a bit of scheduling problems, and they all want to come back at the same time as their friend, but we try to do what we can. And then lastly, community liaison. There will be varied abilities across the country and across the international partners that we have in terms of experience. Some of them will need a lot of hand-holding, by which I mean regular phone calls, regular follow-ups, regular discussions. Some of them actually just need some intervention. Now, the real key to that is the patient and the family themselves. So, in terms of transition, we aim to move patients from the left-hand side here through to the right-hand side. So patients and their families should have knowledge of their own spinal injury. There's no point in me coming in, doing something, talking to the nurse and then leaving again. The whole thing is education and a journey that you have to take the patient on. Over time, that should move to the patient being able to independently articulate their needs. Now, what that looks like for a 4-year-old is going to be different to a 16-year-old, but again, you have to tailor this to the patient. You should then get to the point where the patient has ownership of their own healthcare. So they can turn up at a hospital that has no experience of cord injury at all and say, here is my problem, this is my background of cord injury, this is the reason I'm coming to you, and this is what I think I need. And that might be, I've got a spinal cord injury, I don't feel very well, something is wrong, I don't know what, you need to phone my cord injury centre and speak to them about what needs to happen. At the very basic level, but it's about empowering the patients to know there's something wrong with them, that they can take hold of that pathway. Now, this all sounds very well and good. What are the reasons to not do this? Well, there are reasons to not bother having such a service and such a follow-up. Number one, it's time-consuming. Most of us work in systems where there's a degree of opportunity cost. If you decide to do one thing, you're not doing something else. Now, that may be that you're spending money on that one thing. It may just be that you're dedicating clinician and therapist time to that one thing, so you're not doing something else. You also need a specialist MDT for this. It's not something that you can see a few cases of and then be able to run with. I use this example. We hope this doesn't happen, but if anyone here suddenly develops appendicitis, I can probably just about remember how to remove your appendix, but you don't want me to do it because I haven't done it in quite some time. You want someone who does this all day, every day, and can do it with their eyes closed. This sort of follow-up is resource intensive because this isn't just see a patient, talk to them about their story, and then send them away with a letter. This is about investigating things which they themselves may not yet realise. Your orthotic surveillance, your renal surveillance, etc. And therefore, it is expensive. And if you talk to any hospital managers, certainly in the UK, that's what they want to know about. How much is this going to cost us? And why are you doing it? So, what I say to them is this: we go back to the complications of paediatric cord injury. Now, these are not exact figures that I've put up here, and the currency doesn't matter. But the point is that these dysfunctions over a lifetime can cost significant amounts of money. These are estimates taken from various papers of how much dysfunction in these areas costs per year. All right? Now, given these are UK pounds, the exchange rate at the moment is probably you times this by 12, you get krona. The one thing I point out to you is the skeletal development. If you can avoid a child needing corrective scoliosis surgery, you save in the UK £40,000. This is a significant amount of money. So this brings us back to that course. Now, you need to decide what your frequency is going to be, but as we've discussed here, people don't follow straight courses through life. Even if I look at my own career, I didn't plan on becoming a paediatric cord injury specialist. It's something that happened whilst I was paying attention to something else. As such, you need these regular check-ins to see where this is going wrong, or if it's going wrong. And so those white lines there are our annual reviews until we get to adulthood. That doesn't mean all problems are over in adulthood, but it means that that developmental side of things, which we spoke about at the very beginning, is less of a problem. Now, this slide here is purely indicative. These are not hard figures by any means. What I want to show you here is we know generally prevention is better than cure in healthcare for many reasons. But for one of them is that ill health compounds cost over time. If you can wait until you are in your 50s or 60s before you start to get the ill health that's coming to all of us, your cumulative lifetime costs, whether it's loss of earnings, whether it's hospital costs, whether it's system costs, is less. If that begins at age 6, actually your lifetime cost is going to be compounded. So the indication here is that red line across the bottom is the cost of doing follow-up. If you assume that in pounds it costs about £10,000 a year. If you look at the estimated costs from the previous slide, if you avoid those associated lifetime costs, you see that there is a cumulative effect. So actually, the longer you do this, the more money you end up saving. In a government-based insurance system, this therefore makes sense. You have to see how it works for your providers. But it is the argument against the idea that this is too expensive to do. Actually, not getting it right early on is expensive over the lifetime of the patient, not only in monetary terms, but also in physical health and in psychological health. So, what I would say is this. Pediatric cord injury is compounded by development, which is what makes it more complex than adult cord injury. Adolescence is particularly difficult. You can take your 4-year-old who's injured and teach them everything. They can be the model patient. And then, as they should do, they get to those early teenage years and things are not going to work as smoothly as they did before. Now, that's not a reason to avoid doing it. That's a reason to make things as good as they can be just before that adolescence, because you know you're going to go through a rocky period. And then lastly, early recognition, we know, improves outcome. One of the tools in the kit for early recognition is review by those with expertise in the field. Because if you can pick this up early, you can improve the lifetime outcome for the patient.